Hi everyone, this is our presentation on renal failure patients. So we'll look at both acute and chronic renal failure and then the interventions appropriate for that patient in the complex care setting. The other part of today's presentation is the pancreatitis or acute pancreatitis. So that is on a separate PowerPoint voiceover, so please look for that. Our objectives are listed here. These are the same objectives from your objectives in reading. So just look over those and be familiar with those. This is a review, so I'm not really going to go into the review at all, but this is the renal anatomy, and this is the functional unit of the kidneys. So this is where all the problems, all the diseases and disorders take place related to acute renal failure. As you lose functioning nephrons, then it shows up as renal insufficiency, then to renal failure. So you can see the loops there, the glomerulus, there's a Bowman's capsule, and then the collecting system. So I'm sure you've had this previously in anatomy and physiology, so I will move past this. And then another slide for you to think about would be if there's failure in this system, what are you going to see? And that would be related, of course, to what the normal functions are. So here's our normal functions of the renal system. And it's all about fluid volume, it's about electrolyte balance, it's acid bases. The kidneys also produce various enzymes, erythropoietin for red blood cell production, blood pressure control, again, hormonal control, some of that's for fluid volumes, and you can see other regulations there. But the reason for this slide is that as you think about it, this is going to be what you're going to see and how this is going to affect the renal system. And here are your signs and symptoms of renal disease if your kidneys are not functioning normally. Aging has a role with renal function. There is a kind of a standard degradation in renal function as individuals age, and that would be once over 30. Every decade, people lose about 10% of their functioning nephrons. So it sounds like horrible that you'll eventually be out of nephrons. It's not quite as bad if people take good care of their kidney health and don't smoke and have a good lifestyle. But this is expected. As we age, we will have less redundancy available to us should the patient get ill. So individuals that are older are going to have more tenuous outcomes should they have their kidneys affected. There's decreased reserve because of this. And here's our normal aging process. We lose glomeruli, we lose muscle mass, and that affects our creatinine. Our response to thirst and ADH decreases, so there's some dehydration concerns as we age. So here again is more review. This is our general renal assessments. You've had most of this in your assessment course in your junior year. We look carefully at the health history and any risk factors for renal diseases and disorders. Blood pressure is a big part of the assessment. Also, your production of urine. What's the urine look like? How is the intake and output? What's the voiding patterns? And has there been a history of urinary tract infections? For assessments then, if we're concerned about the renal system pain, it could be anywhere along the renal system. So it could, of course, be the bladder, which would be a lower pubic area. It could be the ureters, which run alongside the groin and lower abdomen. And then if it's truly kidney pain, I think you remember where that is. That would be if there's soreness or tenderness in the back, that costovertebral angle right below the ribs on the right and left side. We also look in general, is there edema on the patient? And if there's any concerns, the provider will run a variety of diagnostic tests. And many of the studies, if we're really looking carefully at their tissue, might include contrast media. So we have to be careful with those and protect the patient's kidneys prior to any of those dye studies, or potentially do this study without a dye. So it might be a CT scan without contrast dye. As far as acute renal failure, you can see it affects a good percentage of individuals in intensive care. The mortality rate is fairly high, and renal failure can occur fairly rapidly or over several days, and it's a decline in renal function. And you see what the characteristics are. Azotemia would be protein in the blood, so that would indicate the BUN and protein degradation is happening. There's a urine output disturbances. We really want over like 30 cc's. This says 40 cc's an hour. Some outputs are calculated by the patient's weight, so you'll see so many milliliters per kilogram per hour, but we really are looking at that 30 or 40 cc's per hour for good renal health. And then acute renal failure does have a lot of electrolyte imbalances we'll talk about. Renal insufficiency means that the kidneys are still functioning. There's about 25% of the glomeruli, or the nephrons, are retained. And renal insufficiency indicates that the BUN and creatinine and the different levels are slightly elevated, but are stable. And we'll talk about insufficiency in a little bit, but that would be the criteria for insufficiency versus failure. We have a variety of categories regarding the cause of acute renal failure. And you see these are pre, intra, or post-renal. So causative categories right here. You see pre-renal are typically the majority of the cases. And these recover well if there's early intervention. So this is where nursing really gets a lot of credit, to recognize that the person is dehydrated or bleeding, or their urine outputs are dropping. We'll look at pre-renal in just a second, but nursing really affects that. Intrarenal, meaning diseases or toxins that affect the renal tissue itself. These tend to have poorer outcomes. And then post-renal would be those conditions that are past the kidney, that cause pressure on the kidney and cause damage in acute renal failure. So let's look at some of those. This is a nice visual. Pre-renal really refers to the vascular supply, or the blood supply coming into the kidneys via the renal arteries. So there is some kind of issue with the perfusion of the kidneys. Intrarenal would be, it's pointing directly to the kidney, so that means it's directly causing problems with the parenchyma of the tissue of the kidney. Post-renal means anything past the kidney, so that would be the whole collecting system, the bladder, the ureter, that would be the urethra, that would be indicative of a post-renal disorder. So again, let's keep moving and look at those. Pre-renal. So let's look at this. So again, we talked about this is quite a majority of the cases, and this really relates to any type of hypovolemic situation. And the rule when there's hypovolemia or heavy bleeding or a big event, the body really tries to salvage the most critical organs, which would be the heart, the lungs, the brain, and unfortunately the kidneys don't make the list. So if someone is very severely volume depleted, the volume that typically is moving to the kidneys is diverted off and moved into the core to the major organs. So the kidneys then would not be perfused well. So again, this would be severe volume depletion via dehydration, via fluid loss. This would be a decreased cardiac output, such as in severe heart failure. And you can see some of the criteria there. The mean arterial pressure is dropping, the output is dropping. One potential cause too of pre-renal would be overuse of NSAIDs, because this would decrease the capillary pressure moving into the Bowman's capsule. Our intrarenal causes then, you see those, the big one is acute tubular necrosis, where there's some type of injury to the epithelium and the tubules. It can be from internal agents. It can be rhabdomyolysis, where there's a buildup of large molecules of protein that kind of clog up the Bowman's capsule. It could also be from different nephrotoxic drugs that damage the basement membranes. And post-renals are obstructive. So any obstruction along from the renal pelvis out to the urethra. So these can be mechanical or functional causes. This can easily be tumors. This can be benign prostatic hypertrophy. This can be renal calculi. So let's look more specifically. I said that pre-renal was typically related to cardiac output or hypovolemia. So you see the causes there. It can be excess or inappropriate use of diuretics. Burns cause a lot of hypovolemia, as the individual is like losing fluids because their skin and their protection is gone to prevent dehydration. But decreased cardiac output after a large MI, after a congestive heart failure. So if you see patients being cared for major cardiac events, you'll see people are very carefully assessing their renal status. And our big issue is prevent, prevent, prevent. So get on top of all the good perfusion and output issues to make sure the kidneys are salvaged as well. Another cause of pre-renal would be vasodilation. So any severe vasodilation could drop blood pressure and reduce perfusion. And then hypoperfusion, we'll look at this with shock, where the kidneys aren't perfused due to the effects of shock or sepsis. Intrarenal cause, again, these are a direct assault on the tissue itself. Now you'll see toward the bottom, you see NSAIDs listed again, so they're kind of the double whammy. They're a pre- and intrarenal cause of renal failure. Our major then would be acute tubular necrosis. But you have a couple others. There could be infections of the kidneys. There could be vascular changes. Here's some of our major nephrotoxins, the gentamicin, the amphotericin, the vancomycin. You'll always see those run by kinetics, where they're actually measuring the level of the drug in the body when it's at its peak and then it's at its trough. And they do that to make sure when it's at its peak, it's therapeutic without being excessive, which would cause nephro and ototoxicity for those drugs. Chemicals as well. Antifreeze is a very toxic agent to the kidneys, and I'd say in the last decade or so, it was by law decreed that if companies that made antifreeze had to add a bittering agent, because it kind of looks like a weird glow-in-the-dark Kool-Aid. It's like a bluish green color, and surprisingly, children like to try to taste it. So that was a huge help. So that bittering agent is a big help for reducing intrarenal causes from that. Now here's a look at some kidney damage. Usually the kidneys are very nice and deep pink, almost reddish or reddy, and you can see how light pink and pale this is. So this shows what the kidney looks like after acute tubular necrosis. This kidney obviously didn't make it, and this was a pathology examination of a kidney. Our post-renals. Post-renals, again, are any blockages past the renal pelvis into the collecting system post-kidney. So these can be calculi. This can be like a neurogenic bladder, means the bladder is just not functioning, it's overfilling and it's not emptying, so therefore the backup moves up into the kidneys themselves, and the extra pressure then damages the kidney tissue. Neoplasms can do the same thing, and also benign prostatic hypertrophy. If that causes enough of a stricture, then you'd have blockage, excuse me, blockage of the outflow. And here we have a very nice visualization of some of these options with calculi. Calculi can really form anywhere. You see it all the way into the renal pelvis to block outflow. Here, this would affect the entire kidney. This would affect the entire kidney as well. And the one that's in the top of the urethra as it connects to the bladder, that would actually affect both kidneys and damage both kidneys. With acute renal failure, there is a predictive, very predictable course of how the disease, the failure presents. And the one thing that alters the presentation would be if the patient's acute enough and then goes on dialysis, then you would not see all of the final phases of the renal failure progress. So there's typically some onset symptoms. There's a maintenance phase with less urine produced. Then the phase where the kidneys start to generate urine again in very mass quantities, and then where the kidney is actually recovering. So let's break this down a little bit. So the onset phase is the initial injury to the kidney, and we can prevent it. It takes good, astute assessment and thinking. And is this person, this person comes in for one thing, but if they're at risk for kidney failure, can we prevent it? So our whole issue is that the vascular component is reduced, or the glomerular filtration rate is decreased. And once that happens and ischemia results, then there's damage to the tubules. The symptoms are typically vague, so what we try to do is watch that mean arterial pressure. You'll see those on the vital sign instruments that you roll into the room, and you get a blood pressure and everything, and all of a sudden it'll show MAP. So MAP is the mean arterial pressure. In some instances, you might see like a MAP of 60 or 65 is okay. The patient's usually pretty critically ill, but we really want to keep the MAPs, again, around 70 or above, just to maintain perfusion to the kidney. The onset phase then, results in less hydration, less oxygenation, and then injury occurs at the end of onset. After onset, we have maintenance. And maintenance, why they call it maintenance, I do not know, but this is your oliguric anuric phase, and it is the inability of the kidney to function normally. So you'll see fluids are not being excreted, we have electrolytes become imbalanced, and then we have a lack of ability for the kidneys to remove the nitrogenous metabolic wastes. So it can last for a few days, and you see the concern is the longer it goes, the worse the prognosis, or the longer the healing is going to take. And this ischemic, sloughed necrotic tissue will block the flow of urine. And here's some of our signs and symptoms. As they can become more and more toxic, they become nauseated, they may have trouble, they may become more obtunded, they're drowsy, they're confused. They will show edema, and the edema could be peripheral or it can be pulmonary, so it can look like congestive heart failure with pulmonary edema. It can be also edema of the extremities. And here's our output per day. So even if they're producing 50 cc's of urine, they'd call that an anuric output. 400 only is oliguric. So they'll develop hypertension, and think for a moment why they would develop hypertension. And that's correct, they're overhydrated. So they're overhydrated, and there's more volume in the vascular system, therefore more pressure. Now you'll see their labs become very abnormal. BUN and creatinine are rising. They're not removing potassium, so that gets elevated, and that's kind of critical for our cardiac function. They show more phosphate, lower calciums, And due to not necessarily the bicarb, but all the different acids that are retained, they develop metabolic acidosis, and that's really a clear indication of acute renal failure is metabolic acidosis. Once they've gone through that phase, now if it's only a few days, 4 or 5 days, they might not need to start dialysis if their BUN and creatinine, if their electrolytes aren't wildly abnormal. And if they can get to this phase without dialysis, all of a sudden they will start producing a lot of fluid. And it says like 3+ liters a day. So if your patient is losing 3 liters of fluid a day, you would be checking for dehydration. Also, we have all kinds of electrolytes being lost, so you would be looking to see what the daily electrolytes are like, and also watching for the side effects of those, or the effects of those. This can last for a week or two. Now, not all patients go into diuretic phase, because if their oliguric and anuric phase isn't too long, is long and pronounced, and their labs are getting abnormal, this is where they will go on hemodialysis to correct this. They don't let them linger in severe kidney failure. They want to protect the rest of the body systems. So some patients you don't see the diuretic phase because they're on dialysis anyway. So again, this could last for a while. Here's our signs and symptoms, and that's the loss of a lot of urine, but it's a very, very dilute urine. There's a volume depletion. They become tachycardic because their volume is low. Their blood pressure could be low. They lose weight from all the fluids, but they're also kind of clearing mentally. Their kidneys still aren't functioning well, but they are starting to heal and starting to remove the toxins and balance the electrolytes a little bit better. So your big thing here would be monitor those electrolytes and watch for dehydration, and potentially good blood pressure, pulses, fluid, rehydrate. So it's kind of a nice balancing act that we're doing here for the patient. And finally, we have recovery phase, and you see that is 1+ here. That's not a typo. So this takes quite a while for the patient to recover. And you can see that there's typically residual damage, but their glomerular filtration rate and their function really can get back pretty much to normal, close to normal. If the individual is younger, they should recover their function as long as it hasn't been a severe episode. But about 1/3 of them will have renal insufficiency. They do not need dialysis, but their BUNs and creatinines will be elevated, so they'll have to do like every 6 months or whatever the provider asks for, monitoring to make sure this isn't getting worse, especially if they're older. They're going to lose renal function as they age, so any little thing that affects their kidneys could push them from insufficiency to failure. There are some then that require long-term dialysis, so we'll look at that in a little bit. And that would mean they're in renal failure and their kidneys are too damaged to do the appropriate function that kidneys would do. Here's our acute renal failure findings. We just talked about some of those. There's some fluid imbalances, so in the maintenance phase, they are not urinating enough. In the diuretic phase, they're losing too much fluid, so we would really be assessing those. Lots of electrolytes. We'll look at those more specifically. The big one is potassium, and the reason for that is it affects the cardiac status so much they could easily go into a variety of potentially dangerous dysrhythmias. So let's look at some of this. Here's our acute renal failures. So hyperkalemia is the big one. And the mechanisms for removing that are lost. So you can see potassiums are over 5.5. Usually it's 3.5 to 5 milliequivalents per liter is normal. But this is over 5.5. If we're getting into 7 to 10, we're getting real dangerous. I've seen 8s and 9s, and that's like scary. And those people came in for urgent dialysis and had very unusual looking cardiac rhythms. And as they progressed through the dialysis, you could see them. The rhythms got back to normal. Their QRS, which was extremely wide, just got back to normal. So it's very dramatic with the correction of the potassium balances. As far as treatments, obviously I just said dialysis, and that is a controlled way of removing toxins and electrolytes and regaining balance. The other treatment that's very effective is to give an insulin drip. And this is kind of a controlled situation. You're giving insulin. The potassium moves with the insulin into the cells, so you have less serum potassium. Obviously, you want to give glucose with the insulin, so you don't want to cause severe hypoglycemia. But this is a very appropriate treatment for hyperkalemia, especially in the complex care area. You would be doing this on quite an acutely ill individual in ICU. There's times you could give bicarbonate if they had severe acidosis, but the little star is there is like, give carefully, because you don't want to put the patient into alkalosis, because then your body is going to try to get it back into normal. So bicarb is used sparingly and carefully. The other treatment for hypokalemia would be calcium gluconate, which exchanges with the potassium and reduces it. And there are other treatments for less acute. K-exolate is, if you look at the word, it's a medication. So K would stand for potassium, and exolate would mean to excrete. So this is an oral medication they take, and that binds in the GI system with the serum calcium and moves it into the GI system where it's excreted. And then there are dietary restrictions. So the diet of the renal failure patients very difficult, and they always work with a dietitian for this. So you'd have to be careful with high potassium foods. So if you think for a minute, I would like you to think about what foods are rich in potassium, so be aware of those. But some examples then would be oranges and orange juice, bananas, avocados. Unfortunately, not a lot of guacamole if you have renal failure. And I think it would be dried, like raisins and prunes. So just be aware that there are some dietary restrictions for the potassium. There's some other labs. The sodium gets affected more by the person's hydration status. If they have too much fluid, they're overhydrated, then their sodium is more dilute, so they're hyponatremic. If they get a little dehydrated, it could be hypernatremia. So basically, you can see some of the things you're watching for hypo, but you would work with the provider who would be either adding or decreasing fluids. As far as calcium, renal damage can affect the vitamin D production, excuse me, and therefore they tend to have low calcium. So you would want to do calcium supplements for these individuals. Phosphates, the inverse, so you would want to restrict phosphorus. So if you are looking at dietary phosphorus, you would think if the person's low in calcium, we should really push like dairy products, milk and milk products, but they actually prefer you not to push milk products because it's high in phosphates. So they would more likely be on calcium supplements and then avoiding dairy for the phosphates. Magnesium is a problem if the individual is taking magnesium orally, so that would be like antacid use. So if they need an antacid, they could not use magnesium-based antacids. A calcium-based antacid would be a real good option because that would be an antacid and it would have calcium. Other laboratory findings, creatinine is our most reliable indicator. It's very much related to kidney function. And we look at the trend. Again, I don't know if I've said this before, but Mary Beth Lyons, who retired this year, she was at Central DuPage, and one of her favorite phrases was, "The trend is your friend." So always watch the trending in all the labs. BUN is not a great reliable indicator. It's very protein based. So if the individual is taking a lot of protein that day, their BUN could pop up a little bit. The next day, the famous example is the person who goes to do one of the challenges for like the 24-ounce steak challenge. If you can finish the whole steak in an hour, then you get your name on the wall or whatever the prize is, but their BUNs go up the next day. So it's all about protein intake. Other laboratory findings is metabolic acidosis really is clearly a marker for renal failure. So the various ions cannot be removed, the acids can't be removed. There's some respiratory compensation. And if you think of respiratory compensation for metabolic acidosis, you would think, are they breathing more or are they breathing less? And they would be breathing more because they want to get rid of excess CO2, which is the acid equivalent in the renal, in the respiratory system. So when they're severely ill, if they're in acute renal failure, they will be severely metabolic. They'll have severe metabolic acidosis, and their response to that would be very deep, rapid respirations, which are called Kussmaul, Kussmal. And they're really almost like big grunting respirations. You can hear them down the hall, big, this person is just desperate to get rid of extra carbon dioxide. There's less production of the bicarb, so therefore more tending toward acidosis. As far as our goals, here are our goals for the therapy for the patient in renal failure. Really about fluid volumes and electrolytes. You heard that. You're hearing a little bit about nutrition with potassium and all that, but if you think about it, they really need to avoid too much protein because that would be our nitrogenous wastes, and that would increase the need for those toxins, ureas, ammonias, to be removed from the body. Prevent infection. This is real. Especially when we get to chronic renal failure, the patient's set up for like immune system blunting, so more infection concerns. Emotional needs. There's a lot that goes into caring for yourself when you have renal failure, and it's stressful. It's very depressing as well. And education needs. There's some diagnoses, and these should be familiar. I would say of all these, the strange one that pops out would be the impaired skin integrity. If they're in acute renal failure for a while they're healing, and then of course in chronic renal failure, they get very itchy skin. It's like the nitrogenous wastes seem to like to deposit on the skin and cause a lot of pruritus and itching, and it's just kind of a daily thing. It can interrupt their sleep and all. So you see our diagnoses there for acute renal failure. Here's some of our medications to deal with fluid volumes. If the person's in diuresis, then we want to correct their volumes by adding. So crystalloids or colloids. And think about, do you know the difference between a crystalloid and a colloid? So a crystalloid is our typical IV fluids. Normal saline, lactated ringers, dextrose and water. Colloids, though, are blood products and plasma. So those would be helpful if the patient is, since they have renal damage, if they're not producing a lot of red blood cells with their lack of epigen or erythropoietin. They could also receive a unit of blood now and then to bolster their hemoglobin and hematocrit. Hypervolemia, here's some options for this. We could, obviously, they could be on dialysis. There's some other medications they could give. The osmotics, loop diuretics seem like a good idea, but since they're working on a part of the renal system that's not well functioning, they've decided that it doesn't really give them a lot of good results, especially in older patients. The thiazides are maybe, as are the potassium sparing, so really we've got to get the renal system to heal so it can be responsive to some of our diuretics. If individuals are identified as having renal insufficiency, we as nurses and the providers also need to be very aware that they should not be taking NSAIDs, and they also should not be on ACE inhibitors, which could cause furthering of their insufficiency. And the issue with the ACEs and NSAIDs really is to talk about the previous slide a little bit. It's very important for nurses to be aware of the contraindicated medications for patients to help just protect them and advocate for them. Here's some other nursing interventions. Excuse me. So the fluid observations and interventions, good monitoring, watching the edema, watching the weight. Weight is excellent. And weight is really good because you can actually hide about 4 pounds of fluid on you until you start seeing edema. So in the early phases, you might not see edema, and they easily could be gaining fluid, therefore weight. Good vital signs, listen to lungs, jugular vein distension, that would have to be pretty overhydrated. And then again, looking at all the labs, we have H and H there, so not only if they've been in acute renal failure for a while, are they not producing erythropoietin, but if they've got fluid overload, then they have some dilutional effects and their hemoglobin hematocrits will drop. Fluid restrictions are great. Diuretics, again, administer as ordered, but good observations after administering. Not all of them are good options for the patient. Here's other nursing interventions. Watching the output. We want to make sure that if there's any healthy kidney tissue in there, as their kidneys are healing, they get good output and good perfusion. So much of what we would do with our cardiac patients, vital signs, heart rate, listen to lung sounds, keep the head of the bed elevated for better perfusion. Some other interventions then. We just talked about quite a bit of these, so I don't think I need to repeat these. Bleeding times are important. Their platelets are off. And then ABGs, we did talk about metabolic acidosis being a hallmark, and especially in the acutely ill renal failure patient. Here's some of our nursing interventions. Good balance of rest and activity. They get pretty fatigued with this, so if they're going for procedures or doing things and then you want them up in the chair for a little bit, it might be, how about a nap first, then up in the chair for lunch or dinner or whatever. But just good balance of rest and activity. Prevent injury. We can see that they could certainly have hypotension, they could have fall risk, they have skin integrity issues, and then also preventing infection, not only with this type of patient, but with all of our patients, just to be careful there. The imbalances in their electrolytes and their ABGs can actually, as I said, blunt the immune system response. So they're a little more susceptible to infection. And then antibiotics, again, if they're on an antibiotic that could cause renal failure, they need to have the peaks and troughs monitored on some of those medications. And continuing with our interventions, this is a very stressful time. They don't know if they're going to be on dialysis for the rest of their life, or if this is just an intermittent thing. If they're younger, this is certainly going to affect their job. They're going to have to be in a dialysis center maybe 3 times a week. They do not feel well after dialysis, but there's a lot of depression involved, and with all the toxins and the shifting of the electrolytes, it does kind of cause personality changes and depression. Patient family education. This is a lot of information to absorb. If it's an acute issue, this is kind of, their lives could be changed in a day or two as far as, all right, you've got diet restrictions, you've got fluid restrictions, you can't do this, be careful with injury and infection. Here's the signs and symptoms of a variety of problems you might encounter, and then they'll be set up for a dialysis. Or if it's severe, they're chronic and it's the end stage, then it would be transplantation options. And those don't come easily. Let's talk a little bit about dialysis. I do want to let you know that in the Blackboard site under web links, I've now finally, after 2 weeks, put in some of the videos that I think are helpful. If you go into the class videos for 2020 and snoop around, you will see a dialysis, about a 9-minute dialysis presentation. And this woman is very interesting. She is a chronic dialysis patient. She has a unbelievable shunt that you can see from about half a mile away. It shows her being started on the dialysis procedure, and she kind of walks you through that. So I always think it's very interesting, and just be prepared for this enormous fistula on her arm. It's the best fistula I've ever seen, but it is kind of a amazingly big fistula. So dialysis is the process of replacing the kidney function. And you can see it allows for movement of fluids and particles, so osmosis and diffusion, some ultrafiltration, which is done under pressure. There's 3 kinds of dialysis. The one I have up there is in the web links is a hemodialysis. You should be able to find some other peritoneal dialysis if you're interested, but I thought the hemo was most interesting. So acute renal failure would be potentially a continuous renal replacement therapy. And this is for the sickest of our patients. They have very poor blood pressure, they have multi-system diseases, they have a long list of chronic underlying diseases, and they're kind of barely hanging on. We can still do dialysis on them, but it has to be this really slow, gentle, continuous format. And then there's some other chronic renal. For acute, we can use hemodialysis as well, but the patient is usually much less ill than the high acuity patient on CRRT. But then chronic would be hemodialysis and then peritoneal dialysis. So CRRT, we'll spend a couple minutes on this. You may have seen this done at the bedside at your work, or if you've had a chance to take a patient to ICU prior to this rotation. But it's continuous, as it says. It's a fine ultrafiltration method, and it works best on unstable patients, especially with blood pressure problems. They can use it with or without the hemodialysis machine. They have these cartridges that do the filtration. If it's without the hemodialysis, then the blood pressure kind of drives this. Sometimes when you prime a hemodialysis dialyzing machine and put the patient on it, they have a drop of blood pressure as they shift their blood out of the body. And this is concerning for some of our acutely ill patients. They use a dialysate, and that's a fluid that has a variety of electrolytes and inclusions that either they're trying by osmosis or diffusion to move in or move out of the body. So obviously they'll want to move fluids out, they'll want to move potassium out, they'll want to move toxins out. So they've established those concentration gradients to help all these move to their appropriate places and then leave the patient's blood levels at a healthier level. So here's what this looks like. Like I said, there's these little cassettes set up at the patient's bedside. So they'll, again, if it's continuous, it's kind of working as a replacement kidney. So we have to make sure that the system remains patent, that there's no disconnection, there's no air in the line, prevent infection. So if you look at the picture with the nurse in it, this is a what's wrong with this picture. This picture drives me crazy, but I leave it up there because the dialysis nurse should have her gloves on and should have a mask on. So we can learn something from others' mistakes. So as far as nursing interventions for the acutely ill patient, it would be, let's look at some nutritional issues. So we're done with CRRT. Let's look at some nutritional issues. So the dietitians are great for the patient's age and size, what's the healthy body weight. They will help us monitor albumins and proteins, help with all the different supplements. And when people get toxic, the toxins, especially the nitrogenous waste, really kill the appetite. So it's helpful to have smaller meals, to have them visually appealing if possible, but also to appeal to their appetite. When the patient is extremely ill, they might need to be on parenteral nutrition. And again, if we're avoiding the proteins, then they would be using the different fat emulsions for a lot of energy and also the carbohydrates. So in general, here's the renal diet. They need enough calories for healing. They need low protein to reduce the nitrogenous wastes. We do restrict the sodium and phosphates and potassium, and their carbohydrates should be about 100 a day. And here's a visual for you. When I was a new nurse and we would have patients that came in with acute renal failure, and they were not acutely ill because I worked a big med-surg floor, but their diet, while they were kind of getting over and recovering from their renal disease, their diet would be, at the bedside, they would be allowed hard candy. So there's your carbohydrates. There would be ice chips. So there's your fluid restriction, which I don't quite have up here. And then we didn't have the fat emulsions, so they would have little like pads of butter that they could snack on, which was horrible and sitting on ice. But if you think about it, it's a terrible vision to have in your head, but it kind of shows you there's no protein in there. The calories are coming from those horrible butters and from the hard candies. Now, obviously, they would get trays here and there, but that was the renal diet at the bedside that I cannot get out of my brain. So here's our diets. If they're on hemodialysis, they have to be a little stricter with the protein and the potassiums and the water, fluids. But if they are on peritoneal dialysis, they have a little bit more allowance on fluids because the peritoneal dialysis is usually done daily and done several times a day. So hemodialysis is typically done 3 times a week. So you have to see they have to be more careful on their days off of dialysis so they don't have toxic buildup. There's good information from the food pyramid or the food plate they have now regarding this type of diet. Let's look at some of our complications. And we did talk about watching the H&H. Complications could be, development of chronic renal failure, end-stage renal disease. So complications would include infections and the other things we looked at before. So here's a little case study. I'll have you look at that. This is from your study guide. And you have a patient who was admitted a couple days ago. He has uncontrolled diabetes and an infection. He's had a couple episodes of hypotension. He's got some medications on board. And this morning, here's your assessment. He's a little confused, drowsy, vital signs, lungs. He's got a little bit of something going on there, something going on cardiac. So let's look at some of this. And we say, what type of renal failure? Do you think this is pre-renal, intrarenal, or post-renal? So we can eliminate post-renal right away. We don't see anything that's talking about blockage of urine outflow. So do you think he has pre-renal failure? And I think we have a little bit here about pre-renal because he's had a couple episodes of hypotension, and that would affect the pressure and then the perfusion of his kidneys. So that would be a concern. Does he have intrarenal failure? And actually we have a couple concerns here with intrarenal failure. He has diabetes and infected wound, so that's kind of a risk factor and a concern, especially if he's got infection, but he's getting gentamicin and vancomycin, so those are high-risk medications. Okay, so risk factors, we don't have an age here, but we have the diabetes, we have an infection. What other labs and assessment information would be of interest? Well, all those labs that we talked about previously. You have a BU and a creatinine. Would be nice to know his electrolytes, maybe an ABG on this gentleman. Let's move back to risk factor for a moment. We don't know if he has hypertension, but hypertension is always a concern with renal disease. He doesn't have an active temperature, which is good. And orders, I'll let you think about those, but let's look at some of his other assessment findings. We've got quite a bit. We've got that he's drowsy and confused. So that's kind of, you know, his BUN is pretty high, so is his creatinine. He's also has fine crackles in his bases and some edema, so he definitely is in fluid overload. He's got a jugular vein distension, fluid overload. Hypoactive bowel sounds. As people become toxic, generally their GI system slows down. We have the weight gain. If we look at cardiac, we have S1, S2, and those are normal. And think about, again, when do you see an S3? And there's one instance where an S3 is normal. So S1, S2, normal. S3 typically means fluid overload, like congestive heart failure. And the normal presentation would be from Professor Berta's class. This could well be seen normally in a pregnant woman because of all the extra volume. But other than that, this is abnormal, and this is another confirmation assessment for fluid overload. So again, that's look over that a little bit. Think about the orders that might be anticipated. And I'll let you think about that on your own. Okay, so here's just tells you like the progression of renal failure from acute to a chronic. And you can see that there are different gradations based on the nephron loss. So you have renal impairment or insufficiency. Now, renal insufficiency really doesn't start till, you can see they only have about 25% of their nephrons left. So there's so much redundancy in the kidney. This is really helpful, but you get to a point where your BUN and creatinine are going to be rising. There's going to be a little bit more fluid in the system. They'll have some anemia from that, and also from the damage to the erythropoietin production. When we get to renal failure, you see that we've really got severe damage. There's only about 20% or 10% of normal function. So we see all the classic symptoms of kidney disease. And then finally end stage, and this is when we're really looking at is transplantation an option, or they have long-term dialysis. Here's some other causes of chronic renal disease. You can see any type of glomerular dysfunction, and we saw our patient had diabetes and was hypertensive. but any kind of infection or inflammation into the glomerulus. Sickle cell disease is a big concern in our African American population. Other systemic diseases, SLE means systemic lupus erythematosus, and the kidney can be affected in that. HIV, and then chronic renal disease can be from chronic urinary tract obstructions that keep flaring up. And then we have a couple other possibilities for chronic renal disease as people age. And then here would be our renal failure assessments. There is a really nice visual in your text if you look in your renal section. And it's kind of a full page, and it has an individual, and next to the individual it really breaks down all the different body systems that are affected. For assessments then, really good risk factor assessments. We've talked about some of those. As far as effects by system, I have some more detailed information in a moment or two under chronic, but we'll look at those shortly. Then you can see it really affects every system, which is why it's such a devastating disorder. Oh, so here we go. Once the individual gets into chronic, here are some of the effects by system, and you can then extrapolate how your assessment would go. For the hematopoietic, you can see some of those assessments there. Are they anemic? Are they fatigued? Are they bruising? And this is kind of concerning for our patients. Cardiovascular, what's their blood pressure, what's their pulse, are they having rhythm changes? Remember, we talked about rhythm changes due to an electrolyte, which would be potassium. Here's our respiratory assessments. Are they rapid respirations? Do they have those deep, rapid, grunting respirations? This uremic fetor is when they're in severe kidney failure. They have a really kind of a sour breath, and they're actually exhaling some of their nitrogenous wastes through their respiratory system. This can happen if people decide to come off of dialysis and decide they've had a good life and want to not continue anymore. Here's our GIs: nausea, diarrhea, constipation, anorexia. In our neurologic, if severe, and they could have convulsions as well. Skeletal, they do tend to have osteoporosis. The skin, if a person's had renal failure for a long time, they have this unusual bronzy, it's not quite bronzy, browner color to them, and it's just kind of a chronic sign of kidney disease. As I said, they can be itchy. If they again decide to not continue with their dialysis, decide that they just don't want to do this anymore, and decide to stop all their dialysis, not only is that uremic fetor or that breath up here, then they get this, before they pass away, they'll actually be like sweating out crystals of like uric acid, and it produces this strange, almost glittery look, especially on the face. So what we do for the patient's family is really try to clean the face and like wash their face carefully and their skin, because it just kind of looks, it's a different look that might be upsetting for the patient's family. And then here's some of our reproductive system issues. Our treatment goals for chronic: fluids, electrolytes, look out for the anemia, and all the other issues that we see here. And you can imagine, for someone in chronic renal failure, all the medications they have. The patients that were always kind of distressing to give medications to were the chronic renal patients, where you might have to walk in with like a handful of of supplements and iron and antidepressives and antihypertensives, and it just, the list goes on and on for their medications. Here's our responsibilities, and this kind of relates back to our assessments. So I won't spend a lot of time for this. So good assessments, good interventions. You can see this patient is a real challenge. You just have to think constantly about what are you seeing, what is your assessment telling you, what do you need to relay to the provider, and inquire with the patient even more. Here's some of our medical interventions. So again, fluids, a little bit of sodium intake, but definitely all the dietary issues with potassium and calcium and phosphorus. Social service will help for any setup for hemodialysis or peritoneal dialysis. Lots of pharmacology. Their RAAS system in the kidney is all basically damaged, so lots of antihypertensive, lots of electrolytes. The epigen is frequently given during dialysis, and if they have other coexisting treatments, you know, if they are diabetic and have other diseases, we have to do all the medications for those. And once dialysis is usually started, they usually drop the diuretics because that's their fluid volume. Their intervention would be the dialysis. And then again, it's an agreed upon dialysis method. So if they're choosing hemodialysis, excuse me, you have a sample of that in your videos, and it's the process of just moving the blood out of the body into the dialysis machine. They do require access via either a fistula, which are two vessels, an artery and a vein that are sewn together and allowed to mature for about 8 weeks. They become very distended, especially the venous part of this. So two vessels, an artery and a vein, usually in the arm, are like surgically connected, and after about 6 weeks the vein really becomes distended and it can be seen under the skin. So this would provide access for the hemodialysis needles. You would assess for a bruit and a thrill, and I know you had this previously in assessment, but you would hear the bruit. So if you put your stethoscope gently over the site, you would hear whoosh, 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 with the heartbeat. And then the thrill would be like the buzzing that you feel. Less likely, you would have an arteriovenous graft, which it's like a synthetic soft tube that comes out of one artery and a vein, and it's external. So what's happened is you disconnect the graft, and you could attach the hemodialysis machine to the venous and the arterial port. Those are not used very much, but they can be a nice bridge while you're waiting for a fistula to mature. The other thing that's a good bridge would be any of the dialysis catheters. They're either put in the jugular vein, they can be a subclavian, they can be femoral if the patient's like acutely ill and not very responsive, but they're can be put in and used quite immediately, and they're temporary, so they would have to be replaced from time to time. So here are some of the visuals. The graft, it's hard to see, but there's the tubing of the graft comes out, again, from an artery to a vein, and usually about right here there's a connection that can be opened, and then they can attach the hemodialysis machine to that, and then it's reattached again. As you would notice, if this is sticking out, it could get caught in the linen, so this has to be wrapped very carefully. It is a pain. I've worked with these before, and they're not used very much now, so I'm very happy to hear that. Here would be a temporary hemodialysis catheter. Red and blue port you would see are clamps, and that would tell you arterial and venous. To prevent clotting, they usually load these with some type of thrombolytic agent, and with that we never inject anything into a hemodialysis catheter. That's just the hard and fast rule. And when the tech comes, or the dialysis nurse attaches this, then they do remove whatever agent is in there. They don't inject it into the patient, and then they can start the dialysis up. For the AV fistula, the fistula lies under the skin. They would use the 2 needles to access, again, 1 port to move blood into the dialysis machine and 1 port to return it to the patient. And then we have to watch that for bruising or bleeding or clotting, which would be very concerning. And they do use heparin during the dialysis to make sure there's no clots being formed and pushed into the patient. So our responsibilities before dialysis would be just good assessments. What's their weight, how's their vital signs. Frequently the dialysis patients going for dialysis, their beds will allow for a bed weight. The providers might say which medications are given, which are held. There's pre-dialysis labs that might be drawn. And then the patient is moved to the dialysis area, or they do dialysis in the room. It must be a sterile technique. This is a direct access into the patient, so we do not want problems. Hypotension is a concern, as is a variety of dysrhythmias. Because of the potassium, they tend to jump in and out of different dysrhythmias, including atrial fibrillation. So the dialysis nurses have to know a little bit about dysrhythmia identification and interpretation. If they go to a dialysis center, they usually have some nice comfy lounge chairs. You'll see that in the video. They can put their feet up, and then they can go home. Afterward, if they come back to us, then it would be good assessments. You usually are reported the weight, and then they can have their medications as ordered and eat as ordered. The one thing about patients who are going home to have dialysis, or even after dialysis in the hospital, they really feel awful. So awful, such as, they've just had all their electrolytes played with, their fluid balances. They may have gotten some medications during the procedure. I know it looks like, this is a great cure, but it's really rough on the patient. They really feel wiped out. And when they come back, it might be, I just don't want to eat or do anything. I need a big old nap. And that would be totally fine. For patients going home, sometimes that their dialysis day is go to dialysis, go home, and hit the sofa. And it is pretty disruptive. So again, if someone's on dialysis, it's saving their lives, but it is a kind of an unpleasant lifestyle. Our other option is peritoneal dialysis. And this is where the peritoneum actually acts as the kidney replacement or the dialyzing membrane. So there is a catheter that's placed in the abdomen into the peritoneum, and it just stops about right here. And there'll be a little hub on it, so that when it's not in use, they can just kind of plug the hub or clamp it off. But when the patient needs to do their dialysis run, they actually use it looks almost like twice the size of an IV bag, and that's a dialysis fluid. So they'll have dialysate, and what happens is they will attach the dialysate via tubing with a sterile technique. The patient then allows the fluid to run into the peritoneum. They can either disconnect, or what they'll do is they'll take the flattened bag and kind of roll it up and take the tubing and roll it around the bag and then kind of tuck it into their pants. And the tubing is clamped, so the dialysate has to stay in there. They allow it to stay in the peritoneum for so many hours. That's called their dwell time. It's usually like 3 hours or so, 4 hours. At the end of the time, the concentration differences that are set up allow the electrolytes to move, the fluids to move, and at the end of that time, the bag is then placed on the ground or lower than the abdomen. The clamp is opened, and then the dialysate returns into the bag. So at that point, they're done with one round of their peritoneal dialysis. They usually do several a day. So then they would attach the next bag and go forward. There are some nice dialysis cyclers that are almost look like it looks like an IV pole, but it allows about 4 bags or 6 bags to be attached, and the patient can have this run in and out of them at night. So that's very helpful. And then their days are a little bit freer for them to move around and do whatever they need to do. So one thing that the first time I ever did this with a patient, I had never done this before, obviously. I hadn't even seen it in my clinicals. So I went in there, I kind of read the policy, I talked to someone who'd done it, went in there, and immediately said, okay, I know you know what you're doing because I know you've been on this for over a year or so. So I'm going to set up your dialysis, your dialysate and run it in. But I want you to watch me to make sure I don't break sterile technique. And he knew exactly what I was talking about. They're very cautious about any infection because it can result in peritonitis. So he watched me that I put the gloves on right, that I did the scrub the right amount of time, I attached it carefully. And sometimes your patients or the patient's families are the best teachers because they have to do this and be scrupulous. One thing you teach the patient, or you do, is when the dialysate drains out, you'll need to monitor and look at that. Is it cloudy? Are there any inclusions in there? And you would let the physician know right away. It could be the start of peritonitis. The CAPD is this continuous ambulatory peritoneal dialysis, where they're up and around and moving, and they're doing this continuously. And again, there's a night version of this as well. This could be a preferred treatment if the patient is compliant and has the skills to do this, and also has the storage space for all of the dialysate bags. These are delivered like once or twice a week, and if a couple of these are run a day, they really have to have like almost a dedicated room for the equipment and the supplies. So here's the pluses and minuses between hemo and peritoneal dialysis. So peritoneal's pluses, it's continuous. There's less fluid shifting, and there's less severe electrolyte shifting, so the patient tends to feel better. It's for those really motivated to do self-care. It's fairly easy to learn. They have to be very careful with this. The dietary restrictions are much less. They're using an established catheter, so there's no needle sticks. They can travel. They can make sure when they get to where they're going that their supplies are there. They would just have to have their physician contact a dialysis center, know what kind of dialysate they need, and have it delivered to their hotel or to whoever house they're staying with. It's fairly flexible. It's less harsh on the blood pressure and less stress on the body. Here's some of the negatives. You know, peritonitis can be life-threatening. So they have to be careful, scrupulous with their care. It does tend to lose protein, so strangely enough, they need to improve their protein intake. And you see some triglyceride level issues. The peritoneal catheter is kind of unpleasant to have there. It's a daily reminder. They have to set up a daily dialysis schedule. They might have a little bit of weight gain due to this method, and again, storage space. With the weight gain, they do, and this is not a disadvantage, this is just a side note, when the dialysate is infused, as you would guess, the patient, the first time or two might say, you know, I feel kind of bloated, and you'd have to reassure them, yeah, that's the dialysate, and it's in your abdomen, that's why you feel a little larger in the abdomen and a little more bloated. There are a couple other interventions. We'll talk about transplantation. This would be in patients that are end stage, and this would be a good option for them. other interventions. Really, if they could link up with a good counselor, that will really help them move through this process. Their weakness, sometimes after an acute episode, physical therapy, occupational therapy, very helpful. And again, you see the percentages. At some point, sometimes patients will tell you, I've had a good life, and I think I don't want to do this anymore. And you don't like immediately call and say, okay, we're done with dialysis. It would be kind of start the conversation with them, tell me more, and this is a serious decision. What's going on, and it's not our job to help them make the decision one way or the other, but certainly they're looking for someone to listen to. They would have to just have this discussion with their provider and, of course, with their family. They want everyone on board when they choose this. And then if they decide to do this, it would be maybe 10 days once you're off dialysis that the toxins overwhelm the patient and they pass away. They're not awake toward the end. They're very stuporous and not responsive. They need to say what they need to say before that stage. So, and the family needs to know that they're not going to open their eyes and give them, one last goodbye and I love you. That all needs to be said before they get to the end of the toxicity. Now that is the end of our renal presentation for today. Please remember to access the acute pancreatitis content. It's not a very long PowerPoint, so please do that in preparation for class on Thursday. Hope everyone is well, and I will see you on Thursday in class. Bring your good questions. Also, this information is very helpful for the students, not the pancreatitis, the renal information is helpful for the students that will be in simulation yesterday, and next week I will send some information around to everyone involved in the next couple simulations regarding the renal case study development. You'll need to make sure you're clear on pre, post, and intrarenal information. So hope all is well, and I will see you on Thursday. Bye now.